Okay.
Okay. Good day, everyone. We are on our 18th session of Learning Basic Arthroscopy series of lectures. Today, we have a very interesting program on meniscal repairs. Dr. Shreyash Gajjar from Kokla Ben Durbai Ambani Hospital is going to talk about the tips and tricks of meniscal repair. We also have Dr. Spikermann from Argentina. Dr. Srinivas, do you want to introduce Dr. Shreyash?
Okay. Okay, Doctor. Good evening, everybody. Dr. Shreyash Gajjar is the speaker for today. He'll be speaking on meniscal repair tips and tricks. So he's a consultant orthopedic surgeon at Kokla Ben Dhirubhai Ambani Hospital in Mumbai, with skills in all types of arthroscopic procedures. And he's received fellowship training in arthroscopic surgeries of the knee, ankle, foot, shoulder, elbow, wrist, and hip from UK and Australia. He's a good friend of mine. In the 7 years he has joined Kokla Ben, he has performed about 3,500 surgeries, and which includes more than 3,000 arthroscopic procedures. And he's efficient in sports medicine and related sports injuries, and has treated several professional sports persons and celebrities in Mumbai. And he's also a member of various arthroscopy societies and is regularly invited to be speaker in the national and international arthroscopy conferences. Welcome, Shreyash. Thank you very much for accepting this invite. I'll hand over the screen to you.
Yeah, welcome, Dr. Thank you a lot for accepting to make your presentation on meniscal repairs and sharing your knowledge. And just a second. Okay, so we have Dr. Spikermann Federico from Argentina. He is a knee arthroscopy surgeon with 18 years of orthopedic experience. He is also main member of the Argentinian Arthroscopy Association. He is former member of the Argentinian Rugby Union medical staff, and he is also a member of the SLRD Association. Thank you very much, Dr. Spikermann, for accepting to moderate the session.
Oh, thank you for this invitation.
We look forward to you sharing the knowledge with us.
Thank you. Thank you. A pleasure.
Yeah. Okay. Over to Dr. Shreyash. You can share, sir.
Right. Thank you, Srinivas, Sasi, for this invitation. It's always a pleasure to contribute. And also greetings from Mumbai, India to Dr. Spikermann. Thank you for joining this session. So the topic today is meniscal repair. It is quite a vast topic as far as meniscus goes, and we have progressed significantly over the last several years. And I will share with you my thoughts and my practice as far as treating meniscal tears goes. I work in Mumbai and an arthroscopy and sports medicine surgeon. So we know that menisci of the knee help to increase the congruence of the joint. They also increase contact surface area, contribute to joint stability, increase joint lubrication, allow nutrition to the articular cartilage, help in proprioception, and importantly, act as shock absorbers of the knee joint. If you look at the microstructure and the anatomy, they are concentric, wedge-shaped, and fibrocartilage. The medial meniscus covers 60 to 65% of the medial tibial plateau. The lateral meniscus 80 to 85% of the lateral tibial plateau. And predominantly, it is a type 1 collagen, and the other composition includes fibrochondrocytes, proteoglycans, elastin, and water. And the fibers are circumferentially arranged. As far as the blood supply goes, it is vascular only in the peripheral 25 to 30% and is supplied by the superior and the inferior medial and lateral genicular arteries respectively. As far as the meniscal function goes, it is directly related to the collagen fiber arrangement. It shares the 50% of body weight in extension and around 85% of body weight with the knee 90 degrees flexion. And the posterior horn of the medial meniscus is a secondary stabilizer of the knee, especially in the sagittal plane. Now, historically, the meniscus was thought to be an unimportant or a vestigial structure, and it was removed. It was subsequently recognized that total meniscectomy reduces the joint contact area by 75%. It also increases the peak local contact pressure double, so 200%. And once this importance was recognized, for meniscal tears, partial meniscectomy was done, and the contact pressure was directly proportional to the amount of tissue which was excised during the procedure. It was, however, noted, despite doing a partial meniscectomy, that wherever the meniscus was sacrificed, the contact pressures increased, which led to overloading of the articular cartilage and subchondral bone, which over time led to biomechanical changes in the cartilage, progressing to osteoarthritis. So really, the meniscus is a very important joint preserving tissue. As far as injuries to the meniscus goes, there are two types of tears which are recognized. The traumatic tears are generally seen in younger patients due to a compression and a rotational force. The medial meniscus, being less mobile, is more prone to injury compared to the lateral meniscus. And the lateral meniscus injuries are generally seen commonly in association with ACL tears. As far as degenerative tears go, they're generally seen in the older patient. They can happen spontaneously without any preceding injury or some trivial form of injury. And generally, they present with a complex pattern, unlike the traumatic tears. If you look at the classification, depending on the pattern of the tear, it could be a radial type of tear, it could be an oblique tear, or a flap or parrot beak type of tear. It could be a vertical longitudinal tear, a bucket handle tear, or a complex degenerative tear. Patients typically present with a painful knee. They have mild to moderate swelling, which generally develops overnight, unlike in the ACL injury where the swelling is seen in hours. And the patients present with some form of symptoms like locking, catching, or painful giving way. When one examines the knee, there is presence of effusion in most cases, joint line tenderness corresponding to which meniscus is involved, and the pain causes reduction in joint range of motion. Pain is typically reproduced in deep flexion if the tear is located in the posterior body or posterior horn of the menisci. And the McMurray's test, which has been described with this maneuver, is sensitive in around 34%. So it is not very specific. So a combination of symptoms and clinical findings should help us suspect a possible diagnosis of a meniscal tear. As far as investigations go, in the younger population, the radiographs are not very helpful unless there is some form of associated injury to the bone or some bony avulsions. In the degenerative patient, certainly it helps to determine the extent of osteoarthritis, and weight-bearing views are really important to determine whether or not the meniscal tear has to be treated with surgery. As far as higher investigations go, MRI, either a 1.5 or 3 Tesla is helpful, and it has been shown to have a 95% sensitivity and a 89% specificity for medial meniscal tears, a 80% sensitivity and a 98% specificity for a lateral meniscal tears. In certain cases, typically revision surgery or previous surgeries, an MR arthrogram with a gadolinium type of dye is helpful to try and determine whether there is any new tear And that has been shown to be 94% sensitive and around 54% specific. Apologies for the typing error. Compared to the MRI, so if you do an MR arthrogram, it is almost twice as sensitive compared to just doing a plain MRI. As far as the management of this entity goes, the non-operative treatment involves anti-inflammatory medications and physiotherapy to help return the patients back to function. Typically, the degenerative type of tears will take longer and patient counseling is important. As far as the operative management goes, it is typically reserved for traumatic tears and those with mechanical symptoms. However, it is very important that we don't waste time typically in dealing with the younger group with traumatic and mechanical symptoms, because with physiotherapy, there is a fear that they would lead to a progression causing the tear to be irreparable. As far as surgery goes, as I mentioned earlier, total meniscectomy has shown a very high risk of osteoarthritis. Partial meniscectomy was subsequently adopted, and the aim was to leave a stable meniscal remnant to preserve as much meniscal tissue as possible to reduce the risk of osteoarthritis. And following this type of method, short-term outcomes were good. It allowed rapid resolutions of patient symptoms. It allowed patients to return back to their function and allowed early return of activities as per peer review publications. However, what was not noted about partial meniscectomy was what was the long-term outcomes. And in the last decade or so, we've recognized that as far as long-term goes, initially there were very few studies with only 1 year follow-up, but it was noted that on long-term outcomes, there was radiological progression to osteoarthritis. And also the outcomes were worse the more the meniscus was removed. Hence, in the last decade, there has been significant interest in trying to preserve the meniscus as much as possible, and meniscus repair has shown to have better long-term clinical outcomes and less radiological degeneration. So this is the current line of management for a majority of meniscal tears wherever possible. As far as timing of surgery goes, the advantages of early arthroscopy are typically for the displaced locked bucket handle tear, because these can be reduced and therefore repaired, and also early arthroscopy can be reserved depending on the severity of patient symptoms. And it's very important to remember and recognize that early surgery would allow us to preserve meniscal tissue rather than to delay surgery and compromise on the vascularity and the quality of the toned tissue. So because of the blood supply of the meniscus, typically the meniscal repair was reserved for peripheral tears. And initially it was tried through the open approach, but the problems was that the access was difficult, and it was reserved for concomitant open repair of ligament or periarticular fractures. With the advent of the arthroscope in the 1980s, the meniscal repair principle was adopted or absorbed into arthroscopic techniques. And there were predominantly 3 types of techniques which were developed. The outside in, reserved for the anterior horn type of tears, the inside out, reserved for the anterior half of the body, and the all inside for the posterior half of the body and the posterior horn tears. So if you look at the various options available for meniscal repair, the red zone would allow us to do an all inside type of repair. The tears in the blue zone would be amenable to an all inside in the posterior half and an inside out type of technique in the anterior half of that zone. And for the green zone or the anterior zone, the outside in technique would be the best way to deal with this type of tears. So just to brief you with some principles of doing these repairs. So as far as the outside in technology goes, one needs certain instruments, either straight or curved, and they are low profile with a very small tip to allow us to shuttle the nitinol wire initially and subsequently the suture through the tear to repair it. And these photographs demonstrate how the outside-in technique is performed. So one sees the outside view, wherein the lassos are passed in to the area of interest. And in the arthroscopic view, you can see that they are both in the relevant part to bridge the tear, and then you pass sutures through the eyelets of these lassos, and you can just pass in your suture subsequently and repair it. So this is how it is, and this photograph demonstrates the use of fiber wire type of suture. It is a 2O, so it is low profile. And what is shown on the right photograph is that the suture is captured through the eyelet and then retrieved, and the knots are tied on the capsular side. So we pull back on the loop once the suture is delivered through the lumen, and then we communicate the two via the needles, or you excise the bridge of skin between them to allow us to tie the knot directly over the capsule and allow kind of apposition of the tone areas. So this is how an outside-in technique would look like. This is a PDS type of suture which has been used. As far as the second technique, or the inside-egg technique goes, again, there are specific instruments to be used for it. And this is one such option called the joystick instruments, which has different types of curved and straight lumen cannulas. They are anatomically curved. You can reuse it. And the cannula have an option of flexibility and provide good tactile control. And one can choose the suture material depending on one's preference. And you can see here the bottom photograph shows the options of a straight one and the curve to various. So this is a slight curve, and this is around 35 to 40 degrees of curve. Now, as far as the technique goes, what it amounts to is that you introduce the joystick and you press onto the inner fragment to try and reduce it. And through the lumen, you pass the first suture, you withdraw the joystick and you pass it in the neighboring area. And subsequently, you deliver the two ends of the sutures out on the capsule like the outside-in technique. And then we tie the knots in this area as seen here. And we can have several configurations from back to front to cover the area of the tone menisci as shown in these photographs. So there are dedicated instruments available, and these are the 2O fiber wire meniscal suture sets. Again, these are long to allow us to pass it from within the joint, and even if the soft tissue envelope is wide, it is long enough to allow us to withdraw it out through the skin and then subsequently tie it onto the capsule. And what this type of suture has shown is that it's superior resistance to wear and tear because of the strength of this suture. So this is a video. Again, there are some videos which are prepared for longer talks. So I will just show you very briefly as to what the principle involves. So I'll just play this. So what we are doing here is we've introduced the joystick needle in. It is an autoclavable type of instrument, and we passed one needle through a tape. So initially it was fiber wire, but there was a risk of cutout because it was like a guillotine effect. So now tapes are used. They provide a wider contact area. And then we pass it through one, and then we move it to the neighboring side to bridge the tear. You can see that the tear is right in the periphery here. It is a bucket handle tear, and this tear is in the anterior half. So other types of technique would be difficult to pursue. And here I'm passing the second needle through the lumen. And after that, the joystick cannula is withdrawn, as you will see here shortly. And on the outer side, where the needles have been delivered out of the skin, the two ends of the tapes are pulled, so that will reduce the tear, as you will see here. So these tapes are really broad and prevent the fear of cutout of the sutures, and also allow a wide area of compression. So I'm holding on to the joystick cannula, and my assistant is pulling the sutures equally on both sides. You want an equal thing, and there you can see the horizontal type of mattress type of suture which you have achieved using this type of technique. And as I said, this was a bucket handle tear, and this is the completion. So we did an all inside at the back, and these two sutures in the front, we did an inside out technique. So depending on the nature and the location of the tear, you can kind of apply it. And this was a bucket handle type of tear in a chronic situation. Now, the all-inside technique involves using devices which are knotless, and the meniscal stitch is one such device. And you can see here it has 2 PEEK implants, and these are typically helpful for the tears which are in the posterior horn and the posterior half of the body. Again, the principles are the same, and the idea is to pass the PEEK implant up to the capsule area, so it kind of crosses the meniscal tissue, and then when we pull on to the first knot, it kind of loops and tightens it. So these are the steps, as you can see here, on the diagram here and on the cadaveric, and I will show you a video shortly of how it is. And one can go for a horizontal configuration or a vertical type of configuration. So before I give you some examples of these type of meniscal repairs, it's also important to recognize another type of tear, which is a stable incomplete tear. So you see the superior surface is not involved, it's only the inferior surface. And these are seen in association with ACL injuries. So in my practice, I don't repair them because they are stable and incomplete. So what I do is I rasp the edges and I do some form of synovial abrasion, as you can see here. I'll just replay the second part here. So, that allows some bleeding to happen, but in conjunction with an ACL, you don't need it, because when you're drilling the tunnels or the sockets, there is a bone marrow which passes through. So, the stable incomplete tears need not be repaired. Now, this is an example of an all-inside small peripheral tear. It's a longitudinal type of tear, and it's important to use a cannula for suture management. And you can see here that through a dedicated sleeve, I pass in the meniscal all-inside implant. It's a PEEK implant, so I've passed it with an introducer on one side of the longitudinal tear. And then I will retrieve the slotted cannula and then fire the implant or prime it, and then bring it to the neighboring area, as you will see here shortly, and then pass in the second PEEK implant. And once that is done, we pull on to the suture, and the knot tends to go where the first anchor was deployed, as seen here, and that will reduce the peripheral type of tear. So I've done a longitudinal type of a horizontal mattress type of configuration for this small longitudinal tear, which was in association with an ACL injury. Now for bucket handle tears, as this one, so this was a chronic bucket handle tear, isolated. You can see here this fragment. This patient presented to me around 3 to 4 months after the injury. This is the lateral meniscus we are looking at. You can see the fragment in our vision. And that's the bucket handle fragment. I'm trying to reduce it in that area. It's large fragment, so I could not excise this, but you can see that the tissue is not very healthy. So one needs to clean that tissue, create some bleeding potential, do microfractures, do bone marrow stimulation in the anterior to the ACL attachment on the intercondylar notch to initiate some bleeding potential. So here I'm trying to prepare the area and the fragment, and using the principle that I showed you earlier. So I'm trying to now reduce the tear to check that it stays, and it is staying. It was not just a bucket handle tear, it was also a complex pattern. So you can see a horizontal cleavage type of component, but it was a large fragment, so I really wanted to try and preserve it. So here I have reduced the tear, and I'm holding it with a probe, but one can pass an inside-out suture to reduce the tear and hold it in place. And I will just now play the second video to show that this is the repair of the end result of that. So we have used inside-out techniques in here, and in the front here we have used, we've used the all-inside technique at the back, and in the front we have used an inside-out type of technique to repair this chronic bucket handle tear. And I added some bone marrow stimulation in the intercondylar notch to allow some bleeding potential. The other options are to use orthobiologics like PRP or bone marrow concentrate to create a bleeding stimulation, predominantly in these isolated chronic type of tears where the healing potential tends to be poor. Another type of tear which we tend to see is a horizontal cleavage tear. This is an example in a younger patient in association with an ACL tear. But the horizontal cleavage tears are generally seen in degenerative situations in conjunction with a parameniscal cyst. So one needs to treat it, debride it, check the stable edges. So here you can see that on probing, the meniscal fragment, superior fragment was unstable. So I had to repair it. And what we did was passing horizontal circumferential sutures. There are dedicated instruments available. This is knee scorpion, which I've used. It allows us to pass this low profile fiber wire. And then like we do in shoulder surgery, knots are tied to approximate the superior and the inferior leaves together, as you can see here. And subsequently, a second suture, a centimeter apart, is passed to reduce the neighboring portion of the superior leaf, which was unstable. And again, the sutures are cut, and you can see here that's the end result. The two leaves are approximated, and now the superior fragment is no longer unstable. And that is the repair configuration. This is called a hay bale type of technique, which is essentially the horizontal circumferential suture. Repair has also been extended to radial tears, because we know that radial tear, which extends to the red-white or the white-white zone, and if we remove it, it is equivalent to doing a total meniscectomy, which would lead to rapid progression to osteoarthritis. So radial tears are also repaired, and this is an arthroscopic photograph showing that we pass in these horizontal matrix sutures, depending on the extent of the tear. We pass it from periphery to the center, and if these are in chronic situations, then we should use adjuncts like orthobiologics to allow a healing potential to happen. So, once upon a time, these radial tears were treated with partial meniscectomy or near total meniscectomy, but now we've recognized the importance, and we really have to preserve it, because if the tear does not heal, say for example, there's always an option to go back and trim it to whatever is not healed. As far as the post-operative care following meniscal surgery goes, for partial meniscectomy, my patients are allowed full weight bearing. Straight away, the crutches are discarded once comfortable. Knee range of motion is pretty much allowed right away, and return to sporting activities are permitted around 6 weeks for medial meniscal tears, slightly longer, around 8 to 12 weeks for lateral meniscal tears. Obviously, they need to get the strength back in their knee before they aim to return back to their sports. When meniscal repair is performed, if it's a bucket handle tear, then non-weight bearing is performed. If it's a small or medium-sized tear, patients are allowed toe touch weight bearing. I protect them in a hinged knee brace, more importantly to remind the patient that they really have to be careful and they don't become careless. Knee flexion from 0 to 90 is allowed for the first 6 weeks in the large bucket handle tears, which extend from front to back, and deep squats are allowed around 3 months period for these large type of tears. As far as the outcomes following meniscal repairs goes, it has been shown that the healing rates are better in conjunction with ACL reconstruction, because as I mentioned, there is a healing potential from this bone marrow, which allows a better healing rate. And also if the tear is less than 2 millimeters close to the peripheral rim, because we know that that is an avascular area. Lower healing rate was noted in ACL deficient knees and in tears in the avascular zone. And keeping this in mind, some sort of adjuncts or augmentation for healing has to be added to the procedure. So if we look at the failure rates or the success rates following meniscal repair, studies showed that generally speaking, there is a 19% failure rate for an all inside type of repair, around same for the inside out, and the subjective outcomes and complications were similar in both groups. With the inside out technique, the risk of nerve injury is around 9%. With the all inside, that is very low. However, there is a risk of local irritation, migration of the implant or breakage during the procedure. So it has to be exercised with caution and using a meticulous technique. A meta-analysis to compare meniscal repair with meniscectomy showed that, if you repair the meniscus, the long-term patient-reported outcomes are better. Also, return to activity levels are better than doing a meniscectomy. And also, it has been noted that meniscal repairs have a slightly, failure rate, but still in comparison, it would be worthwhile to do meniscal repairs in the right indications and wherever possible. Some other papers comparing repair with partial meniscectomies, they've shown that, you know, even though meniscal repairs may have a slightly reoperation rate, it is associated with a better long-term outcome, and therefore it is worthwhile trying this type of meniscal preserving technique in our practice. As far as the chronic tears go, the bucket handle, again, meniscal repairs have shown that they lead to good clinical outcomes with a relatively low failure rate, and repair of isolated meniscal tears had a higher risk of failure than repairs performed in conjunction with ACL reconstruction. And once again, to emphasize that therefore some sort of orthobiologic type of augmentation has to be done in these chronic type of situations. In cases where the meniscus is, there is near total or total meniscectomy seen in a pain swelling in the compartment, and with history of subtotal or total meniscectomy, a meniscal replacement, both cadaveric and synthetic, have been performed. The clinical results show that the pain is reduced, the knee function is improved, but these patients should not be advised to return to the same level of activity. Otherwise, the replacement will fail, and the long-term studies are still awaited. Although we know that 10 to 15 to 20-year results are fine, but again, there is a very small number of people across the globe who are doing these type of techniques, and it has not been reproduced in all centers across the world. So as far as meniscal repair goes, the future is to probably consider some form of mechanical abrasion, use a fibrin clot in the chronic tears who have poor vascularity, try and deploy some sort of meniscal neovascularization, the mesenchymal stem cells, and also use 3D patient-specific meniscal scaffolds. So this is one section of the talk which I'm concluding, that the repairing using these three type of technique has certainly led to changes in our treatment. We have adopted limited resections of the meniscal tissue to preserve the meniscus volume and function, because we know the importance of the function of the meniscus. Advanced techniques, skills, and instruments has allowed us to perform these type of complex repairs, and the goal really in the 20th century should be to preserve the meniscus. Now, taking it further and just talking about the chronic tears, why should we repair the chronic ones? Because we know that the knee joint undergoes osteoarthritis even if we remove some form of meniscus, and therefore it is important to preserve it, to try and restore its function. Now, I have talked about this, that even in partial meniscectomy situation, overall it would lead to loss of joint space and collapse, and therefore we should protect the function of the meniscus. I mentioned about this meta-analysis and these studies which show that the repair is better. And historically, we've been repairing it in the peripheral situation because of this blood vascularity, and therefore the success rates were better. But we now need to adopt, and we have been in the recent decade, to go into this white zone, which is important. But two important factors need to be considered when we think about meniscal repair in the chronic situation: patient characteristics and tear characteristics. So in the decision-making process, it is important that the patient has symptoms, and they could be pain, locking, swelling, effusion, tenderness. The contraindications would be poor tissue vascularity during our arthroscopic procedure, older people who have more than 50% degenerative changes, and importantly, poor compliance with rehab, because it's very important to ensure that the procedure is successful. And also, if there is some form of pre-existing instability like the ACL deficient knee, then it has to be addressed in concomitance. Otherwise, the repair will fail because there will be a lot of stress on the repaired area. So as far as indications go, the factors which influence the decision-making are the tear-related symptoms, the reducibility of the tear, the location of the tear, also the pattern of the tear, and also the root tear is another entity which I'll talk about subsequently. Radial tears in the white zone have been a relative contraindication, but as I showed you in my example, we have tried to address these, because if it becomes avascular, there is always an opportunity to go back and trim that part of tissue. So chronic is typically defined as anything which is between 3 weeks to 3 months. The outcomes are mixed, and really in the present day, there is no clear consensus regarding the effect of waiting time on healing. So wherever possible, we should try and repair it. And there are various devices available in the market. Again, MR arthrography, like in revision cases, is helpful to try and identify these chronic meniscal tears. And this important paper by Garrett, these are the findings or the features which are important to assess the outcome following meniscal repair in older patients. So at follow, what I tend to see is that I would classify my repair as successful if my patient at 3 months and further does not have any joint line tenderness which was pre-existent, there is no effusion or locking, and the meniscal test is negative. So this would be a clinical way to determine that the repair has been successful. Henning has described an arthroscopic type of classification wherein a complete healing is noted when the entire meniscal breadth has healed, around 100%, partial healing when more than 50% or 50 to 100% of healing has happened, and failure is when less than half of the meniscus remains unhealed, and that would classify as failure. So in the chronic situation, as you can see here, this is a patient who had meniscal symptoms in association with cartilage lesion. So we performed a microfracture for the cartilage lesion. I'm just going to speed up in the interest of time. And we did a meniscal repair for his small peripheral longitudinal tear. As you will see here, you can see that tear in the background there. I'm probing it. And I'm doing the microfracture. And I've repaired this tear as I did before, but you can see the marrow elements are already coming in, and that would help in the healing of this chronic tear. So because I did a microfracture in association, I did not do any separate bone marrow stimulation or PRP or BMAC. But if the tear is in isolation, then an easy, quick way in theater would be to add a PRP injection. Obviously, we need to make sure that we wash the knee out completely of all the fluid, and then we inject the PRP to ensure that the fluid does not percolate out of the knee joint. Now let's look at these, newer adjuvants, PRP. Is it kind of beneficial? Certainly, the reports have shown that they are helpful, and this another technique for horizontal cleavage chronic tears is the use of fibrin clot. It may not be available in all centers, but this is another option. So what has been done here is that before tying the knots, the fibrin clot has been passed, and then the knots are tied onto the capsular side. So that holds the fibrin clot nicely in apposition with the horizontal cleavage type. And this is an example of the radial tear which I mentioned. Again, depending on the configuration, there are various techniques available even for the skeletally immature patient, and it's very important to preserve, and they will certainly have a better healing rate compared to mature adults. So as far as the chronic tears go, the evidence-based indications are the tears which are in the red and the red-white zone, bucket handle or single plane tears. The joint should be non-arthritic, generally in association with some sort of ligament surgery, because the healing potential is better, and also the results are quite encouraging in meniscal root tears in the presence of early osteoarthritis. So let's finally talk about two important entities, the meniscal root and the meniscal ramp lesions. So again, in the last decade, when we try and understand the importance of the meniscus and preserve it, we also recognize that the meniscal roots are equally important, if not more. And they are entities which anchor the meniscal to the tibial plateau, and radial tears within a centimeter of the meniscal insertion or avulsions are labeled as meniscal root tears. And what a root tear would lead to is failure of the meniscus to convert the axial loads into transverse hoop stresses, which would lead to a large amount of forces, which would cause accelerated cartilage degeneration, with changes comparable to a total meniscectomy. And even, it would lead to meniscal extrusion more than 3 millimeters and wider with time. So if you look at meniscal root tear, if untreated, at 3 months, the joint space would start becoming narrowing, and at 12 months, the joint space would be more than 50% narrow, and these patients would end up with some sort of an arthroplasty procedure. And hence it's important to try and preserve the root wherever possible in the right indications. So meniscal root tear patients could present either in the acute or the chronic situations. They are degenerative type, seen in the middle age, more common in women. The traumatic types are seen in young patients in association with a ligament injury like an ACL or a PCL. Again, the pain would be towards the posterior part of knee, although not almost always. Patients could have mechanical symptoms. There could be pain in deep flexion. A popping sound sometimes is described by the patient during light activities. There would be effusion, presence of joint line tenderness, and the risk factors are presence of varus alignment and a high BMI. And this would be the middle-aged female patient where we commonly encounter the meniscal root tears. And these patients are more or less asymptomatic, and they describe a distinctive episode, a trivial one, which would cause them to develop pain, swelling, and prevent them from returning back to their earlier function. And they are the ones who would most likely be diagnosed to have a meniscal root tears. As far as classification goes, there are 5 types, but the type 2, which is a complete type of oblique tear close to the root, is the most commonly seen in the practice, although root avulsion type of injuries are seen in road traffic accidents or certain high velocity injuries. MRI again is useful for diagnosing root tears, and 3 common signs described are the presence of meniscal extrusion, radial tear. On the axial image you can see here, as marked by the yellow arrow, the presence of the defect, and the ghost sign where on the sagittal view you will see the absence of the root in that cut. So these are the 3 common MRI features of a root tear. As far as the management goes, again, it could be non-operative, doing a partial meniscectomy, or doing a root repair. Non-operative treatment is generally reserved for elderly patients, those with significant comorbidities, with higher BMI, and those with advanced osteoarthritis, the outer bridge 3 and 4, and those with malalignment more than 5 degrees, and if on arthroscopy, the tear is irreparable because of the chronicity and the quality of the tissue, as seen here in this arthroscopic image. So what is the evidence for non-operative treatment? So this study published 3 years ago looked at 52 patients, all in the middle or slightly higher age. It was 62 months follow-up. They noted that there were a very high incidence of failures, and 31% needed to be converted to total knee replacement. So from this paper, this was a paper from Mayo Clinic, and the authors concluded that really non-operative treatment leads to poor clinical outcomes, progression of osteoarthritis, a high rate of conversion through arthroplasty, and the results were worse in women compared to men. If we venture into partial meniscectomy for meniscal root tears, it is generally reserved for patients who have a failed non-operative treatment and still have ongoing pain and complain of locking. They are partial tears with an intact footprint, although the percentage of footprint which is determined to be intact remains unclear as per the published literature. And this level 3 cohort study showed that even partial meniscectomy progresses to significant osteoarthritis, leads to poor clinical outcomes, and almost a 50%, if not more, conversion rate to arthroplasty. And they noted that there was no difference in subjective and objective outcomes compared to the non-operative control group. So really, by doing partial meniscectomy, we are not doing enough. So then we need to think about that, does it mean that we need to repair all sorts of root tears? So this study actually managed to answer the question. It looked from Korea, and a lot of root tear work is being done from South Korea. This is a cohort of 91 patients, almost a long or a mid-term follow-up study at 8 years, which showed a 92% survival rate. But it's very important to recognize that they had strict inclusion criteria. They only operated on patients who had a modified outer bridge grade 3 or a Kellgren-Lawrence grade 2 type of osteoarthritis. They excluded patients who had a varus malalignment of more than 5 degrees, and overall, most of their patients who showed a 92% survival at 8 years were grade 0 or grade 1, and the average joint space was 4.7 mm. So they really picked up the winners, and in those patients, it really showed good results with 92% survival at 8 years. But not to undermine or say the least, patients were advised to follow a strict rehab program and advised crutches for the first 6 weeks. And they were told that they should permanently avoid deep squatting. This is because we know that in deep flexion, there is an significant pressure on that degenerative tissue, which by nature is weak because of the aging process. And therefore, the repair construct can be compromised. And therefore, this authors did not allow deep squats in their patients permanently. Also, only patients who had a body mass index of 25.6 and lower were included in the study. So the message here from this midterm follow-up study is really that we should really pick the right patients so that we can give them good results. So my indications for root repair would be the acute traumatic tears in patients with normal or near normal cartilage, those in association with ligament injuries. In the chronic situations, they would be reserved for symptomatic tears in the young or middle age, but importantly, without significant osteoarthritis. So in my selection, it would be outer bridge grade 1 or 2. So as far as the surgical techniques goes, there are various suture configurations which have been recognized, but the studies have shown that the tibial pull-out technique is most appealing, and these are the two commonly used techniques. The tibial pull-out involves passing the sutures through the root and delivering it through a narrow tunnel transosseously and fixing it with a cortical button on the anterior aspect. The other option is to do a suture anchor, but because the root is posterior, you need to have a posterior medial type of portal, and you need to pass the anchor through that area. But the real concern is that the area is very narrow, and therefore the tibial pull-out technique tends to be most commonly used in practice. So this is an example of an acute lateral meniscal tear in a young patient with concomitant ACL reconstruction. Again, there are dedicated jigs available. So here, instead of a tunnel, I've drilled a socket. So I use what is called as a retrograde drill or a flip cutter. So I make a centimeter of channel, and then I withdraw the drill or the flip cutter. Then I use the dedicated instrument to take the bites through the detached meniscal root. And there are 2 sutures used depending on the extent involved, and each suture is passed individually through that osseous socket and delivered to the anterior tibial cortex. Then subsequently a second suture is passed, and it is best to do it one step at a time to prevent any dangling of the sutures and allow ease in suture management. So you can see here a cinch type of configuration has been followed. You can see my ACL graft in the neighboring area, the one with the blue dye, and I'm then passing the outer suture, and that's the end configuration seen here, and I have tied it over a button onto the anterior cortex. In the degenerative knee, visualization of the knee could be a little difficult because of some osteoarthritic changes. So, this is an example where at the time of arthroscopy, you see that the joint space is narrow. But if one does a percutaneous MCL lengthening like a pie crust technique, so we use some form of low profile needles and make multiple punctures on the femoral side of the MCL just above the superior surface of the meniscus, and you can see that opens up the joint, and that would allow us to reach the root better, because you can see here the space is very narrow compared to what we achieve when we do a percutaneous MCL lengthening. So this should be reserved for situations where the knee is tight and visualization is a compromise, because during the repair, you don't want to damage the cartilage. Now, what would be a good indication in a chronic situation? So this is an example. This is a middle-aged lady who has the type 2 meniscal root tear in association with grade 2 changes in the femoral condyle. And I have kind of repeated the same procedure steps which I did with the acute lateral meniscal tear, but I'll just show you how we do it in the degenerative patients. And again, meticulously 2 stitches are passed. and they are delivered through the socket next to the root attachment anteriorly with the help of this nitinol wire. So there's a shuttling of the suture you can see here, and I have achieved a cinch configuration. And similarly, a second suture is passed and delivered through the osseous tunnel into the anterior tibial cortex. So that's the end results, and we managed to achieve the root back to where it belongs. On the other hand, this would be a bad indication. So you can see a grade 4 changes, bone is exposed, and this is an associated meniscal root tear. So I would not offer a root repair in this patient because it's going to fail. If only the medial compartment is involved, then I would perform an high tibial osteotomy. But if there is a generalized osteoarthritis, then I would just do a debridement type of procedure and leave the root alone. Post-operatively, my patients are allowed partial weight bearing for the first 6 weeks. They are kept in an extension knee brace for the first 2 weeks. Knee range of motion is allowed from week 2 to week 6. And importantly, no squats are allowed for the first 3 months, and deep squats are again not encouraged for lifelong. As far as results goes, there is a significant improvement in the clinical stores. Although we know that we are not able to eliminate meniscal extrusion seen on MRI, and recently there are certain additional techniques of centralization of the menisci which are there. Now, in the interest of this being an overview of meniscal tears, I did not include the meniscal root extrusion reversal technique, but I have started adding that to my meniscal root repairs. And really, this meniscal extrusion is important because that is what is going to prevent collapse and osteoarthritis. And vis-a-vis repairing the meniscal root, we also need to centralize the meniscus into the joint. Moving on to the last entity, the meniscal ramp lesion. Essentially, it's a disruption of the meniscotibial ligaments of the posterior horn of the medial meniscus, as it has been reported as a tear in the peripheral posterior medial meniscus. This study published in the AGSM 6 years ago showed a 17% prevalence in ACL injured patients. Also, it has been shown that sometimes patients have a higher pivot because of these ramp lesions, and it's very important not to miss them and look for them, and preferably look through the posterior medial portal, or at least put this arthroscope in the posterior medial portal so that we don't miss this ramp lesion, which would lead to the failure of our surgery. So till now, the meniscal ramp region was under-recognized because, as we know, it lies in the posterior part, which was a blind spot when we used the standard anterolateral and anterior medial portals. Biomechanical evidence has shown that leaving the ramp lesion generates an increased tibial translation, and therefore patients who present with pain, dysfunction, and altered knee kinematics need surgical treatment, if in isolation or in conjunction with ligament injuries. The pathology has, as I mentioned earlier, has been under-recognized. Now, let me show you what a normal meniscal ramp would look like. So this is an area where I've looked in the posterior medial part, and you can see here that the meniscal capsular ligaments are nicely attached to the back of the ligament. So this is an intact meniscal ramp area compared to this one, where you can see here that there is this lesion here right at the periphery. So through the anterior portal, we would never be able to identify this. But if we put the 30-degree scope into that posterior medial area, like how we do for PCL, we will definitely pick up these ramp lesions. Again, there are certain low-profile instruments available, and one should tend to use it if possible to minimize any damage to the cartilage and make it a quick procedure. They are low profile, and essentially we need to visualize it through the posterior medial portal and pass our sutures. Visualize anteriorly, use the posterior medial portal as an instrument portal, and then we suture it. So I will just show you a video highlighting that. So the arthroscope is coming from the anterior portal, and my instrument is coming from the posterior medial portal. This is the dedicated lasso, which is around 25 degrees low profile. So I'm taking a bite through the capsular tissue and then passing it through to the meniscal area, as you can see here. And through the opening of that lasso, I'm shuttling in the suture. I just use a single portal, but one can use 2 portals in the posterior medial side, one to visualize and one to suture it. And one tip is to suture the central part first and then move on to the periphery. So it becomes easy. The suture management is much easier that way. So I've passed and tied the midline suture first, and then I've gone to the periphery. And that's the end result. We managed to repair these ramp lesions. So what is the evidence? This study in 132 patients showed that 92% had good outcomes with a very low incidence of failure. And the conclusion was that it is a safe, effective procedure. And there is a very high rate of meniscal healing, obviously because of the vascularity in that area. So in summary, for this section of the talk, root tears and ramp lesions are often overlooked. It is important to repair them in the right patients with the right indications. However, what remains unknown is that whether leaving the root tear or repairing it would ultimately alter the progression of cartilage degeneration. And hence, reversing the meniscal extrusion component remains an important part of surgery. I thank you very much for your attention and encourage everyone to preserve the meniscus as and when possible. Thank you.
Excellent.
Thank you very much, Dr. Shreya. That was a very extensive talk on meniscal repair, covering almost every aspect of meniscus repair. I would say this video will definitely serve like a Bible for all the learners who want to know about meniscal repair. Thank you very much. It was very, very useful.
Thank you.
There are a lot of questions already for you.
Okay, let's go for it.
I just want to summarize it for the listeners. So you talked about the anatomy of the meniscus, the anterior, the body, and the posterior, and also the zones. You did talk about the acute injury and the chronic injury. We need to make a clear-cut planning when you need to do a repair based on the chronicity and also based on the pattern of the tear. And the indications are very clear. As much as possible, it is necessary to repair the meniscus and preserve the meniscus. You did talk about evidence and also your protocol for rehabilitation of the patients for both partial meniscectomy and also for meniscal repair. You did also talk a lot about other controversial and recent issues about meniscal replacement. Very important points about posterior horn root repair and also the ramp lesion. Thank you very much. It was a very extensive talk. And coming to questions, in one of the videos you showed an inside out meniscal repair. I mean, it looked like some sort of a tape rather than a suture material. Is it tape that you used?
Yes, so we have advanced as far as these materials and sutures go. As I mentioned during my talk, is that the suture, the worry was that it could act as a guillotine and it might cut through. And also, if you use a tape, being broad, it distributes the area of the repair,
Yep.
and we may also require, it provides a stronger construct, and it will also maybe reduce the number of sutures we use if we use a tape instead.
I totally agree with that. Can you give us some tips on how to access the posterior horn, both in terms of placing the viewing portal and also instrumentation portal? You did talk about puncturing the collateral ligament, and you said that you just want to go above the meniscus. Can you talk a bit about the portal placement in order to access the posterior horn?
So the portals remain the same, more or less, the anterolateral and anteromedial portal. Whenever we are doing a meniscal repair, whether it is in the body or in the root, it is important to use a cannula to make sure that we don't catch our sutures in the fat pad. So suture management becomes easy. Then visualization is extremely important. We need to ensure that we can see our area of interest very clearly. And whilst in a majority, like the younger patients, you don't need to do something like a percutaneous MCL lengthening. Whenever there is associated degenerative changes, or if it's a tight knee, one should not hesitate to do this pie crusting or percutaneous lengthening of the MCL to allow opening of the posterior half of the joint, so that without causing any damage to the femoral condyle, we can pass our sutures. Importantly, we can pass it in the right areas to allow us to reduce the tear and ensure that the repair heals with time.
Okay, thank you very much. And suppose you have a patient for high tibial osteotomy, and the patient also has a meniscal tear. How do you plan your surgery? Because in high tibial osteotomy, you do a little bit of MCL release during the osteotomy. Yeah.
So you elevate the MCL. So generally, the high tibial osteotomy patients would be the ones who would have a root tear in association, because we are talking about the middle-aged, or high BMI and outer bridges, grade 2, 3, or 4 type of patients. So in those cases, it's the root. Now, if one is doing a high tibial osteotomy and we are trying to correct the varus which is more than 5 degrees, there are two lines of thought. One is to repair the root in association, or one is to leave the root alone because we are anyway offloading the medial compartment, for example. Now, and this kind of thinking of leaving the root alone because we are offloading is from the South Korean group, and they have published around 2 years results, and they've showed good results in leaving it rather than repairing it. So I have done a couple of cases, and in this patient group, when I'm doing a high tibial osteotomy for more than 5 degrees of varus, I just leave the root alone, because in a good number of cases, the quality of the root is anyway not very good, and therefore I may not be able to repair the root back to its footprint.
Okay.
Am I audible?
Yeah, there's a small break. Yeah, it's fine now.
Yeah, there's a small delay.
Yeah. Okay. So the next question is, if you have a patient with a meniscal tear along with a meniscal cyst, how do you approach the cyst? In addition to repairing the tear, how do you approach the cyst? Is there anything other than debridement you would like to do?
Shreyash, are you there?
Dr. Spikermann, what is your experience with respect to meniscal cyst? Do you have tips to share with other than meniscal repair in the presence of a cyst?
Yeah, absolutely. In my experience, I remember like 15 years ago, we used to, to do like a combined approach. You do like an arthroscopic repair or meniscectomy, plus, like an outer, the out repair or cystectomy. Okay. But, there are like lots of research published that you shouldn't, you probably would leave the cyst like that, because the origin of the cyst basically is a leakage. It's like a fistula, right? That communicates, the cyst and the joint. So
Yep.
if you repair the meniscal injury and you close, right? You do a closure in the fistula, the cyst will go away itself. So you don't need to do like a combination. So nowadays, what I would do, I would definitely go for a meniscal suture, a partial meniscectomy if needed. If the the free border is like a little, degenerate. You can find like many times you can find like a degeneration. So what I do a suture, I do a partial meniscectomy. All right. But I wouldn't touch the cyst from outside. Okay. So that's my point. And I've been doing great with those cases, right? With those patients.
Yeah. Dr. Spikermann, do you think any of these stable meniscal tears can progress in future?
You mean stable? Okay.
Yeah,
it
stable
depends.
meniscal tears.
Right. So it depends on the, I mean, it has like many risk factors. In my opinion, a high body mass index, and also the level of activity. I think, you know, after a time in those chronic injuries, I have no doubt that the follow-up in those cases, if you follow those patients, you definitely see changes in the x-ray. And I have no doubt that in time, the patient will start to complain about pain and degeneration. So I think that you have to educate the patient. You have to, I mean, if the patient has like a high body mass index, a BMI index, absolutely it has to lose weight and to change the activity. So, I mean, the first thing that you have to do is to differentiate those patients. The high risk, you know, in terms of degeneration in the future, and the low risk patients, okay? And definitely I follow those patients and I'll ask them to come to my office probably like once a year, okay?
And do you have a length of the stable tear, for example, beyond this length of a stable tear in a high risk patient, you will progress with, you will
Yes.
proceed with a meniscal repair?
Yeah, definitely. It's 1 centimeter length, right? Is a threshold. I mean, less than 1 centimeter, you probably can leave it by its own, okay, evolution. And over 1 centimeter, I think you should probably like go for meniscal suture, a repair. So it's 1 centimeter.
What is your technique for outside in repair of the meniscus?
The outside in. You mean, well, for 1 centimeter, depending on the location, if it's a posterior horn, I would, definitely I would use the, I think it's easier if you use the inside out, all inside, okay, technique. But if you're familiar with the protector, with a meniscal protector, okay, you can use the gold standard. You know that the gold standard device and technique is inside out. I don't know if have you ever tried doing like a posterior horn inside out repair? I mean, you can change portals. You can use a meniscal protector. You can use a spoon, right? Even though it's more demanding, okay? Really, I mean, the stabilization that you achieve using the inside out technique, it's amazing. I mean, you will suffer, you know, of a picaro loosening, etc. So it's very useful. And definitely for the body portion, I mean, for the mid portion of the meniscus, I would use the high standard. I mean, the gold standard is the inside out technique. But if you don't have those devices, I mean, if you have the needles and that device, I would use the Abacath, you know, 14G Abacath, and I do the outside in technique. And also you can use it for the anterior part, and you can also use the inside out, the inside out technique for the anterior horn, but it's really very useful. I mean, if you have like a 90 or 45 degree angulation of the cannula, you can definitely use it. Absolutely.
Okay. Dr. Spikermann, do you have experience with the mini open surgery with inside out posterior horn meniscal repair?
Thank you for that question. And why? Because, you know, I wouldn't say that I'm a plastic surgeon, but I do care about, you know, the incisions and the aesthetic point of view. So you can use, like, for example, if you're doing like an inside out technique repair, I usually use like a hook or the probe. Okay, so I go through one of the like mini incisions, like that mini is like 2 millimeters, and I'll try to hook, you know, the other suture. Okay, so what's the outcome of that technique? And now, I'm like more like, stick to the percentage of the, I never had a vascular problem, but I do have like many patients complaining about, pain, probably like a small nerve attrapment. And, the patient complains for 3 or 4 months. So would I change that technique? I'm really considering it because the meniscal is perfectly, reattached, is perfectly sutured, but the patient do complains. And consider that the rate of complication, it's only 1 to 2%. I mean, it's described in the literature, okay? So I'm really considering about, changing my, the hook of those sutures to do like a mini, probably like 1 or 2 centimeter incision. But it happens. It happens, definitely.
Okay. Thank you very much for your points. Dr.
Yo.
Spikermann, when do you think, how do you decide a chronic meniscal tear is repairable? The duration, the character of the meniscus, can you share some information on that?
Okay. I'm part of the society of the side meniscus society. All right. So I think if you have like an Lawrence, KL like 3 or 4, and the first aim is like probably considering that this patient has an advanced stage of osteoarthritis. I think that if it's in his like 40s or 50s, I would do a repair, okay, instead of meniscectomy. I mean, it's easier to say than to do, and you have to, you follow those patients. So if you're doing a presentation, I would probably say like I would do a repair, okay? But the literature and the many research published that if you do a repair, the outcome won't be like worse than doing the meniscectomy. So if it's the right region, if it's the right area, if it's the right lesion, I would do, for example, like a red zone, like a red zone or red white. I would do a repair. If it's in like white red or white, and it has like a 3, Kegel-Lorentz 3 or 4, well, I would do, and if the patient is in his 40s or 50s, I would do a meniscectomy.
Okay.
Okay.
With respect to a chronic tear.
Yeah, in chronic, yeah. In chronic because
right.
If the patient has osteoarthritis, probably the patient has modified the level of the activity. So, most of those patients, that pathology, you'll find it in chronic meniscal injuries and advanced stages of osteoarthritis. So my approach, I would do, if it's a red zone, I would do a repair. If it's in white, red, or white, I would do a meniscectomy in chronic patients. In addition of high tibial, HTO, high tibial osteotomy procedure, definitely.
What is your preferred clinical test for diagnosing meniscal tear?
A meniscal tear? You mean in chronic or in any patient?
Situation? Which clinical test do you prefer to do?
Okay, so images, definitely MRI. We're not familiar in Argentina with the Arto MRI or with contrast. I think you don't need it, but for me, yes. And in terms of clinical maneuvers, I do. For me, flexing, squatting the patient. I think it's a very reliable examination, and I do the typical examination, flexing the knee and doing the with my thumb pushing the meniscus. And for me, it's very important at first not to do surgery, not to do an operation, and started like a rehab protocol for at least 3 months. That was one of my questions that I wanted to ask about, the protocol before going to meniscectomy. I'm not talking about bucket handles and unlocking of the knee. I'm talking about those meniscal tears, symptomatic tears. And would you put those patients in physical therapy first before going to the surgery? That's my protocol. First, physical therapy.
Okay.
Dr. Spikermann, with respect to the posterior horn meniscal tear, sometimes we see that in a chronic situation, the meniscus is not long enough and it has shortened. How do you manage a posterior horn repair in such a situation? Can you put the tunnel closer to the meniscus and not in the midline?
Okay, I don't know if you're familiar with the pie crusting technique. I've been using the pie crusting for the last 2 years, and it really changed not only my coronary arteries, but also the evolution, the outcome of those patients. It really helped me a lot. You do the pie crusting, and I mean, I do that probably like 1 out of 2 out of 10 of those cases, and it helped me a lot, for the repair of the posterior horn. So in terms of the root, okay, I think nowadays we have to repair that. That was one of the points that I disagree with the speaker, because I do if I see a meniscal root, a positive meniscal root torn, even though it's like chronic or acute, I do repair it. I mean, because we don't know. I mean, the follow-up and all the research presented in the literature, I mean, it has not to the follow-up, right? It's not over 4 years. So we don't know what would happen to those patients like in 5 or 10 years. So if you have a meniscal tear, right, meniscal root torn, I do a repair.
Okay, wonderful. Dr. Spikermann, you had a, yeah, please.
Trying to get Dr. Gajjar back onto the, he's having some network issues. I just sent an
It
invite.
happens. It happens.
Please continue in the meantime.
Yeah.
Absolutely.
Dr. Spikermann, you wanted to share some slides. Can you please put them up?
Sure, absolutely. Hopefully we can get the speaker back, because these questions were basically for him, right? So thank you for the invitation.
Yeah, thank you.
And the first question was if you do consider the body mass index as a criteria for meniscal repair or meniscectomy. So I would like you to share your opinion. And
I think we should be having the speaker on board for.
Right.
So personally, I think, I mean, it depends on the age of the patient. If the BMI is very high, and if the patient is very young, say, hello?
Okay.
Sorry, I think I'm just trying to find my.
Okay.
Am I visible, audible?
Yeah,
yes,
you're audible.
Both, yes.
You're
audible
clear.
and visible too.
Yeah, we can see you.
Okay, so if the patient is a young adult, I would repair definitely. It depends on the age. With degenerative changes, I wouldn't.
And I do agree with that. And even in the older patient, it would be best to preserve the meniscus and repair it and keep the patient informed. or certain precaution that he needs to take, and the possibility, higher possibility of failure. However, it would be best in the interest of the patient to proceed on with the repair.
Okay, and let me ask you too about, I mean, if you have a patient with a high BMI and a chronic meniscal, I mean, which is like very common, all right? Here in Argentina, with too many barbecues, you know, too many, you know, flowers and sweets. So we have many patients and many cases, you know, patients like in their like 40s and 50s with a high BMI, with chronic meniscal disease. I mean, like degenerative more than acute, you know, injuries. And what would you do with those patients? Would you educate the patient? What do I mean in terms of educate the patient? Would you tell the patient that you operate on him or her if he reduces the BMI, for example? Would you send the patient, you know, would you put the patient on a strict diet plus physical therapy and tell that patient to come back in 3 months? Would you do that? I'm doing it. I am doing it, definitely. So, I mean, probably like losing 1 or 2 or 3 kilos would change. And also, you know, with physical therapy and, you know, changing the level of the activity, it will help. Consider that every kilogram that the patient, I don't know if you use kilograms or pounds, but in Argentina, we use kilograms. So every kilogram that the patient loses, it will take 7 kilograms away to their knees, you know, especially the patellofemoral joint space, all right? But so if the patient loses 1 kilo, 2 kilo, 3 kilo, 5 kilos, it will be taking 35 kilos out of their knees, because the knee is such a complex joint, you know, that is why, you know, every kilo counts. So many times I'll send the patient back home, physical therapy and losing weight. And if the patient still complaining, I'll do the surgery. So I want to know your opinion about that. Would you educate the patient? It's difficult. It's a tough question.
I think that's a very interesting and mind-pondering question. That's a very good way of approaching it. But on the other hand, I would be concerned about the time lost in repairing the meniscus. What do you say about it?
Okay, it depends on the type of the tear and the age of the patient, isn't it?
Yeah, definitely. I mean, it's different if it's an acute, you know, red zone tear. Okay, but how many cases have you seen of a red, you know, injury, meniscal injury, in patients like over 40 and over 50? Because, you know, that's like, you know, high speed injury in sportsmen, because due to the lack or the decrease of physical activity, you know, over 40 and over 50, you know, even though in Argentina, you know, you see so many like soccer, you know, recreative soccer players, and you can see those you know, patterns of meniscal injuries. But most of those cases, the injury that you see is more degenerative than, you know, like a red zone or bucket handle injury or pattern. Okay, so I think it's different. I think it's also dependent on the lesion. Okay. Yeah. So shall we go? Shall we go further? Oh, okay. Go ahead.
Yeah,
Sasi.
please.
Yeah. Okay. Trying to get him into the session.
Yeah. Is he able to join in?
He has some issues joining. I'm trying to get him through the mobile, if possible.
Through the mobile? Oh,
yeah.
Double cost, high cost. So let's go further with the next slide.
Some of questions here.
Okay.
What is your approach for radial tears approaching periphery of medial and lateral meniscus? I think Shreyash has given a explanation in his presentation. He has presented about that. He has talked about radial tears. They usually are repaired in the cross faction that he has shown the configuration. I think you can also use a cross going from superficial to deep, that's from inferior to superior, or you can place them on the surface of the tear itself. So
yeah, I prefer the side to side, you know, the common fashion. All right. Instead of using
do you
the
place
cross.
them parallelly, or do you place them as a cross?
No, not cross. No, not cross. Parallel.
Parallel. Okay.
And you know, in Argentina, I don't know what they use in Oman or in India, but fewer of the doctors can use the knee scorpion. I don't know if you can get it, or you have to buy it for your own, or the hospital gets your knee scorpion. All right. But in Argentina, you have to get your own knee scorpion. So there are fewer surgeons here, a few surgeons that holds it. So what I would use an inside out technique, definitely, because one of the advantages of the inside out technique is that you place the cannula and you push. Okay, so you press the meniscus and then you pass the needle. All right. So in my point of view, and in my experience, I prefer, because I don't have any scorpion. Okay, so I would use the inside out technique and parallel, and it did for like 3 stitches. Plus, what I do like a combination. I do a repair of the radial tear, and on the wide zone, I do a partial meniscectomy. Okay, because that's a weaker part. Okay, the free border. Okay, so I do a partial meniscectomy, like 1 to 2 millimeters, not more than that, and then I do 3 stitches, parallel, not cross.
Do you do trephining?
Okay. In my experience.
Yeah. Go on, Sasi.
Yeah, sorry. In my experience, I learned my technique from Chile, Dr. Figuera. So I have been doing cross repair of the meniscus, and I don't specifically have the experience with the parallel stitches, but in my hand, the cross stitches have worked very well, and I have been very happy with the strength of the repair. And again, I use inside out repair, because most of the radial tears in my patient population have been in the body of the meniscus. So inside out repair has been very useful in my hands.
I have used outside in, so yeah, you can use the needles coming from the outside. It's for the patient population here, it's much cheaper. You don't have to use anything new for repairing. So
okay, and what do you think about, you know, like when you do like a cross fashion suture?
Yeah.
Probably you can get an overlap of the borders of the meniscal injury. Do you know what I mean? It's like overlapping it. All right.
Yeah. I never had that, because what happens is I pass the cross stitches, and I don't tie each of them separately. I pass them, and finally I do them together. So there is never an overlap.
Oh, okay.
They come end to end.
Yeah,
they come end to end, and I have a feeling that I have a feeling that the compression is very strong, and because cross, we are not only dependent on cross fiber, because the longitudinal fibers can sort of give way. Longitudinal fibers of the meniscus sort of can give way when theoretically, when you're using a horizontal stitch, and the cross stitch can hold the longitudinal fibers and the crisscross fibers, everything together, and the stitch theoretically could be stronger.
Okay.
Another question here is, what are the reduction techniques for irreducible tears? I presume it's bucket handle tear. I think reduction techniques of a bucket handle tear.
Yeah, yeah.
So you mean how to? You mean
Or
how
How to
how to
reduce?
reduce? How to reduce?
Yes.
Yeah.
Well, I think it's quite easy. Depending on if it's the medial or the lateral meniscus, in order to reduce medial bucket handle, extrude, I mean, protrusion into the intercondylar area, you have to do like a valgus. And what I use a trocar. Okay, so I push it, I do a valgus plus, and then I push it back with the trocar, okay, of the shaft of the arthroscope. And then I try to, I've been doing, I mean, the last time I've done that, I think it was 2 months ago. What you can do, if it's, I mean, once you reduce it, you can use like an abacat, all right, to use it like an anchor, like a temporary anchor. And then you start, doing the suture, okay? And if it's lateral, you have to do like a varus, of course. That's your question?
Yeah.
That is what you asked me? Okay. So I think you can, I mean, you can fight with the meniscus at first, but if you do like the right maneuver, a varus or a valgus, you can reduce it easily.
Okay. Okay.
Chronic tear. Sometimes it's difficult for the chronic tear to reduce. Say if it is 6 months or so, it becomes very difficult.
I had a few cases. I had a few cases of those. Also, I've seen a patient, I think it was 2 years ago. There was like the bucket handle was chronic, but chronic in terms of years, like years. I know the patient probably was like when he was in his 20s, and the patient was, when he came to my office, he was in his 40s, and it was really definitely chronic. And what the patient complained is not about, blocking or blockage of the knee, but because of, swelling and pain, but it was not too bad. So I operated on that patient or that case, and it was not difficult to reduce it. It wasn't difficult. I mean, you have to, I use a shaver, in the intercondylar, to remove soft tissue, some soft tissue, and then I released it, and I reduce it.
Okay. Dr. Spikermann, there is a question from the audience. You do pie crusting of the medial collateral ligament for a medial meniscus. Similarly, can you do that for a lateral meniscus? Can you pie crust the lateral collateral ligament?
I mean, pie crusting is for the medial, for the for the MCL. You can do, but I wouldn't do, definitely I wouldn't do, a pie crusting for the lateral ligament. No, and I only, because it's easier to, when you do like a four shape and you do like a valgus, sorry, like a varus reduction, knee flexion. I think the most difficult technique is to open, the medial compartment, because the lateral compartment is easier to open, okay? But the medial compartment, I mean, especially in those those patients, with varus and with degenerative disease, and that medial compartment is really tight, and it helped me a lot. I think it changed my, those cases that you had to like fight, with that posterior horn, okay, and after incorporating the pie crusting to my technique, it really helped me a lot, because you can get like 4 millimeters. For example, if the medial compartment, you can open it 4 millimeters after. After the pie crusting, you can open it till 8 millimeters, or probably like 1 centimeter. And the patient complains for 1-2 weeks or a month, but then the patient won't complain because of the middle collateral ligament vascularity. Okay, because it heals itself. So it's very useful. You can get 4 more millimeters, you know, over the. So it helps a lot. Definitely.
Another question is, what are your indications for repairing a torn discoid meniscus?
Discoid meniscus. Thank you. 5 years ago, in one of my jobs, I worked for the commerce union. So there are too many shops and stores, and it's a huge. It has like over 4 million patients in Argentina. So they offer me to look after and take over the pediatrician cases and the pediatrician knee problems. So I've been seeing like many discoid meniscus. I've seen 4 cases of medial meniscus. Medial discoid meniscus, which is really very uncommon. It's very rare. What I would do, so going to the point, going to the question, I would do both combination, meniscal suture inside out plus meniscectomy. Okay, so I do both. And definitely you have to, it's different in Argentina, because in Argentina, you have to ask for the meniscal suture. You have to ask to the insurance before the surgery. You don't have a meniscal device bank in the OR like in the US. In the US, you have like a vending machine, you press a button, a code, and you can get the device. In Argentina, you have to ask, you have to order before the surgery. And it's really, even though it's cost effective, and we are talking about, pediatric patients, the meniscal sutures are really very expensive, especially, those imported, Arthrex and Limbatic Conmed, it's very expensive, but I would use it. I would have it in the OR, but you can use Avicat, and you can do you can use Micryl too, 2.0, okay, or 1.0. Yes.
Okay, Dr. Spikermann, do you have any contraindications for repair of a posterior horn root tear?
Okay, so the speaker said that he would definitely not repair a meniscal root in chronic cases. I disagree. I don't disagree, 100%. I disagree like 50, 80%. But if the patient is, a correct BMI, and it's not the patient is like in his 40s or 50s, I would do the repair, definitely.
Yeah, I think he mentioned outer bridge grade 3 and 4, he wouldn't repair, isn't it? 1 and 2.
Yeah. I know. I don't know why. Probably because of the outcome, But outcome. What is outcome? Outcome is like 1-2 years follow up, or outcome is like 5-10 years outcome. There are not too many research published in the literature about 10 years follow up. There are a few. Okay, so you have to consider the age of the patient. Okay. So is the speaker back? No, we were able to put him back. No.
I think.
I don't think he'll be able to join. He's got issues with the connection there. I think we'll have to manage.
Okay, so I'll go further. So the second question is, what's your point of view in terms of, or your criteria for employer-based health insurance? That is a hot topic. What do I mean? Would you go for a meniscal repair? Would you go for a meniscectomy? Or would you do like a non-surgical treatment approach? So, you know what we're talking about, right? Those labor patients that are referred to you to solve. So what do they want? Is the same that the company wants? Is the same that the patient wants? Okay, so this is really a very hot topic that probably like we should take like 1 or 2 hours talking about that, or a whole, not a research, a whole like conference or a presentation. Because what would you do? I mean, are you familiar with these patients?
Well, in India, we don't have, very few patients have employer. There are different types of patients we see in India. And health insurance is actually catching up, but it's not the majority type of patients. So when you say employer health insurance, it basically means a certain type of patients, isn't it? So it's not that categorized here in India, actually. A majority of them pay from their own pockets. And some of them are supported by the government and some by the insurance, health insurance. So there are different categories of patients in India.
Okay.
So viewers
I would like to share my I'd like to share.
Yeah,
I'd like to share my experience here in Oman. We do see three categories of patients. One is the cash patients. The next is health insurance patients. They own health insurance. And as you have pointed out, we do have the employer health insurance kind of patients. Those are actually like the workers with work site injury. We call it on-campus injury or work site injury. So they are paid by the employer who have common health insurance coverage for everyone by himself. So we do face such patients, and it is a bit of a difficult situation. But the final goal has to be in terms of the goodwill of the patient, and we need to. Sometimes we do have to sort of have a long discussion with the employer in terms of the goodwill of the patient.
Well, I think that is a very hot topic also, Sasi, because, research. I mean, we have to stand on the meniscus side, not on the business side, all right? Even though the company wants you to do a meniscectomy and put the patient back to work as soon as possible, okay? Literature and research and, all the publication stands for a meniscal repair. Okay, because at least it will take like 1, 2, 3 months back. Because I mean, we're talking about sport level activity back in 6 months. But for if you work in a factory or if you work, or if you work in an office, you can be back like in 2 months. If you work in a factory, like 3, 4 months. Okay, but because of these companies, they don't care about the patient. Okay, and you work for them. Okay, so do you have to do what they want? Or okay, so that's what we have to change. Our point of view, we have to change our attitude against those cases. So we always, the first is do not harm, take care of the patient and do the best for the patient. Okay. So we're talking about, save the meniscus. Really, don't forget about that.
I think that's a very, very strong point you have made out there. And the literature has shown clear-cut evidence of improvement in outcome on the long term with meniscal repair. So there is no question of
Absolutely.
there is. I mean, if the outcomes were equal, then there has to be some decision that has to be made on one side. But in a meniscal repair, I think the outcomes are clearly better on the long term than a partial meniscectomy. So I think for the goodwill of the patient, we will have to preserve the meniscus.
Absolutely. Next question. What's your criteria for degenerative meniscal injuries in patients age over 40? Would you do non-surgical? Would you do a meniscectomy? Or would you do a crossover? What do I mean in crossover? I mean in those patients treated non-surgically that, in the study or in the long term or mid-term, they want to cross over to the surgical group, okay? And in non-surgical, and listen to this, would you do only physical therapy? Would you do cortical injection plus HA? would you do HA, which is hyaluronic acid? Would you do PRP or PRP plus hyaluronic acid? So that is also a hot topic. So non-surgical, over 40, non-surgical or surgical?
Okay. Yeah, please, Dr. Srinivas.
So it basically depends on the type of tear, isn't it? So how do you classify it as degenerative tear or a traumatic tear? Traumatic tear basically involves a significant amount of trauma, whereas degenerative tears, in history you can find out whether it's a significant trauma or it's a degenerative type. Usually it's some kind of a twisting, mild twisting type of injury. They come with tear of the meniscus. So those patients, if it is a degenerative tear, I generally treat them conservatively with just physiotherapy. I don't go for any injections. I also look at the x-rays, see how much of degeneration there is in the joint. If there is a significant amount of degeneration, I might recommend a PRP injection. Otherwise, I just treat them conservatively. If they come back, or if they don't improve, or if they come back with significantly increased symptoms, then I take them for meniscectomy, a partial meniscectomy.
Okay.
Okay.
Yes, I agree.
I do agree with most
Sasi?
of what Dr. Srinivas said, but we do have to consider the physiological age of the patient and the mobility, the future working capacity of the patient. So, and obviously the local factors also that include both the joint, that is the cartilage. The joint behaves like an organ. You need to work on the cartilage, MRI wise, the subchondral bone, and obviously the meniscus as such. So it's a joint decision. It's a pooled decision that is to be taken. And there are studies, there is evidence to say that meniscal degenerative meniscus tear doesn't fare differently with surgery in comparison to conservative treatment. So my preference wouldn't be a surgical management. However, there is evidence to say that regenerative techniques have worked with respect to meniscal healing, both in the acute and in the chronic state. And we are giving a shot for the meniscus and the patient, and these regenerative techniques are also helpful for the joint arthritis. So I would definitely work on it. I would definitely work on trying some sort of a regenerative technique that is cell based, either a PRP or bone marrow aspiration concentrate, or even the stromal vascular fraction that is getting more and more popular. I would prefer a bone marrow concentrate or a stromal vascular fraction rather than a PRP, considering the higher and better outcomes with this technique.
Good, good. So what do I do? My criteria is I put the patients into physical therapy for at least 3 months, okay? Not less than 3 months. And if the joint is not good, it has like a KL, like 3 or 4, I would do PRP plus hyaluronic acid. In Argentina, there's a new hyaluronic acid. It's called biphasic, and it's called like reticular. It has two different components. One is like the high molecular, the typical, the very common high molecular hyaluronic acid, plus another portion that can stand in the joint for at least 6-9 months. So I do both. I do both combinations, PRP plus hyaluronic acid. There's a lot of research published about that really, it enhances, doing both therapies at the same time. But if the KL, the Kegel-Lorentz, is like a 3-4, but if the KL like 1 or 2, only physical therapy. But I have a few cases of, crossing over the patients with non-surgical and one that I had to do, because I see, when I ask them the MRI, I saw like a bone edema. So that's probably that the meniscus is not working well, and it's not, supporting the pressure and transmitting it to the tibia side. So with like a mild and a minor, meniscectomy, it will help a lot, in transmitting the pressure from the femur to the tibia. And many times the bone marrow, the bone edema goes away, right?
Yep.
And then I treat the osteoarthritis or the degenerative, depending on the grade. Okay. So I think
Okay.
I think we agree. Symptoms, I do recommend arthroscopy and meniscectomy. If they have mechanical symptoms like locking,
perfect.
I do recommend arthroscopy. Couple of more short questions. I think is MRI mandatory post-op after bucket handle tear repair to see whether it repaired or came back to notch again? I don't think I do MRI after.
No, repair. Neither do I. No. Neither do I. No.
And how do you avoid lateral collateral ligament and popliteus when you do an inside out repair of the lateral meniscus?
Yeah, always. That's a very good question. Thank you for that question. So, I mean, it's anterior. You can work. You can do whatever you want from the popliteal tendon anterior, okay, to anterior, not to posterior. Okay, if you don't have the spoon, if you don't have the meniscal protector, the only thing that you can do is either use a knee scorpion or an all inside technique. Okay, but if you have the meniscal protector, if you change the portal and you change from the, your approach is from the anterior medial portal, you can avoid the nerve. The common peroneal nerve.
Yeah. Okay. I think that's a very good point, and you have stressed on an important landmark to be safe. That's a very good point. Yes,
definitely. Okay, I think we have, well, the last question is about the rump lesion. Okay, considering as a rotational unstabilizer or instabilizer factor and a possible origin for a future, back in the handle, all right, meniscal injury. That is one of the problems of the, it starts with like a 1-2 centimeter rump lesion, and it will, evolve with a back in the handle in the future, okay? With or without the ACL repair, okay? But 60% of the rump lesions are not detected through the AM or the anterolateral portal. So on a regular basis, do you seek for rump lesion? Do you seek, but honestly, because we've been talking about, rump lesions for the last 3 or 4 years. Okay, so it's like a hot topic. It's like a trending topic nowadays for us, for the knee surgeon. So would you seek it on the MRI? Would you seek it? Would you change the portals? Would you do, because the best portal is the posterior medial portal. It's like an accessory portal, or you don't seek it. And if you use a probe and you palpate the posterior horn and you see like it's a little loosey, and then you look for it.
I think it's a very difficult question to answer. There's more and more awareness regarding the posterior rump lesion, and there is no way in which we can increase the identify the patients at risk of a posterior rump lesion. So I'm not sure if it is actually necessary for all patients to undergo a posterior medial portal assessment. That's an important question I would like to get answered by a senior person.
I think I would seek as much as possible to identify a ramp lesion. If there is a big pivot shift, I think there's more likely to be a ramp lesion. So MRI, we know it may not show properly. So it has to be probed. And I think most of the cases you can identify when you put your scope in the notch and go behind and have a look. You should be able to identify that.
Yeah. So what I do, I use a probe, okay, and if the posterior horn is a little loosey, okay, so I think that we have to incorporate that pearl that I mean in all of the ACLs that we do, because it will take you only like 10 seconds, okay, to palpate, not to see, not only see,
okay,
yeah, but use a probe, okay, and yes,
You
you use a probe, put the probe, yes, behind the meniscus, and try
I
to.
think you have.
There is some evidence that if it is a very small ramp lesion, not displaced, you could just leave it.
Absolutely.
If it's a big one, you'll have to repair it, because that results depend on an unstable lesion.
Yeah, okay. I think you have made it. You have been very clever in mentioning seek, not see.
Yes.
Yeah, no, seek, of course.
Yeah.
Yes, because how many ramp lesions have you seen like accidentally, right? And also in the MRI, okay, it's very difficult to see. I mean, to observe it, you know, before the surgery. But I think that's a hot topic. All right. I mean, it takes like 10 seconds. Use a probe.
Yeah.
You know, put some, you know, traction forward.
Yeah.
Okay. And so I mean, if you have like a doubt, I mean, any doubt, what you have to do is you have to, you know, to perform a posterior, you know, an accessory portal.
Yep. Yep.
Okay.
I think that's a very, very important point that you have made out. I think we covered almost everything extensively in a meniscus. This has been the longest program for us. Thank you very much for making it a beautiful program.
Last question.
Yeah, sure.
One, only 1 minute. So in terms of a meniscal extrusion due to a meniscal root injury, okay, what is your approach? You do a repair, only the root, or you do a repair root plus repairing the extrusion? And it is probably like the hottest and the latest topic. You know, Arthrex has published a technique on, you know, repairing and reducing the meniscal extrusion. So, I mean, that's quite difficult.
Yeah, okay. Unfortunately, I don't have experience in this.
No, neither do I.
I don't have experience in extrusion repair, but I think if it is osteoarthritis, as Shreyash has mentioned, outer bridge 1 and 2, you can repair the root. 3 and 4, you can leave it. Leave the root repair because it's already osteoarthritic knee. But regarding reducing the extrusion, I don't have experience with it. If obviously if the knee is osteoarthritic significantly, you wouldn't do that. Maybe young patient, early stages, we don't have results of reducing extrusion also, so we don't know how beneficial it is going to be, isn't it?
Yeah, my feeling is that this topic will be like, you know, the ramp, you know, like the ramp lesion and the meniscal root like 10 years ago, that we were like just starting to talk about this and consider this. But I have a feeling that this will be like a hot topic in the future.
I do agree with that.
Yeah. You know, reduce, because you have a meniscus. This is not, you know, for a meniscal transplant. I mean, the patient has its own meniscus.
I thought if you fix the posterior horn, it should reduce, isn't it? Ideally.
Oh, absolutely.
If you fix the posterior horn, it should reduce. Yeah. It has extruded because the posterior horn is torn.
Right. You know, though it's a very demanding technique, because nowadays
in chronic cases you may not be able to put the posterior horn in the place it is. So in those cases you may have to fix it where it is, and in such cases you may have a bit of extrusion, I think.
Oh yes. Yeah, so we'll see in five years.
Yeah,
I think that's the last question.
Yeah, I think it was a very, very extensive program. I think it's going to be very useful for everyone, including us.
Yes.
Thank you for making it a wonderful program.
Unfortunately,
we lost Dr. Shreyash during the program. It's a great loss that we couldn't have him back.
Yeah, but we were lucky to see his presentation. Was amazing.
But
very vast,
very extensive presentation. He shared a lot of his experience. We are thankful
Absolutely.
to Dr. Shreyash for that. I'm sorry
Yeah.
that we lost him halfway during the connection. Okay,
Yeah,
thank you,
sorry to
Dr.
the audience.
Spikermann. Thank you, Dr. Srinivas.
Thank you.
It was
Thank
a
you,
wonderful
Dr.
Greetings
program.
from Buenos Aires, from Argentina.
Thank you.
Greetings.
Yeah,
Come
yeah,
visit
yes,
in the
yes.
future. Come
Yeah,
visit
yeah,
again,
sure,
Sasi.
Yeah, sure, sure.
Bye-bye.
Bye,
Bye-bye.
bye, bye.